Good morning and good afternoon. It is my absolute pleasure to welcome our distinguished chair, chief scientific advisor, 11 esteemed commissioners, and our online audience to this hearing of the Pan-European Commission on Climate and Health. We're grateful to have you with us for this important conversation. Today's hearing is also being broadcast with simultaneous interpretation into Russian. Please check your language options on the Zoom platform if you wish to follow the proceedings in Russian. To begin, I would like to invite Francesca Racioppi, head of the WHO European Center for Environment and Health in Bonn, Germany, to set the scene for our discussion today. Francesca, good morning to you.
Good morning, Sidika, and good morning, everybody. Thank you for introducing me. So today it is an honor for me to stand for Rob Butler, who unfortunately is unable to join us due to some unforeseeable tragic circumstances in his family. Anyway, indeed, this is the second in a series of three virtual hearings that we have had, and these are convened by the Pan-European Commission on Climate and Health to engage with the leading experts, policymakers, and other key stakeholders from diverse backgrounds. These hearings aim to present the latest evidence, share practical examples, and identify gaps and opportunities to accelerate action at the intersection of climate change and health. Insights from these discussions will inform the Commission's forthcoming recommendations for urgent and impactful health and climate action. While the first hearing that was held in June in Reykjavik was about the threats that climate change poses to human health, well-being, and the planet, today's hearing shifts the focus to pragmatic solutions, exploring the opportunities and the co-benefits of addressing these threats through health sector-led adaptation and mitigation measures, spanning from the local to the regional level. As you all know, adaptation is about making our health systems, societies, and the next generations fit to face the future with an inevitably changing climate. In the European region, for example, health action plans are driving a multi-sectoral coordination to reduce preventable excess deaths due to heat. But yet, only 21 out of the 53 member states of the European region have already implemented such a plan, so we have a gap to fill here. Accelerating the development and implementation of these plans is not just a smart policy, it's a life-saving necessity. Mitigation, on the other hand, means going beyond preparing for the impacts of climate change to becoming part of the solution. Our health systems and societies can be climate resilient, but at the same time, they can also be less polluting and low carbon as they achieve their mission. A compelling example in this area is the phasing out, for example, of nitrous oxides as an anesthetic, replacing it by intravenous alternatives that can cut greenhouse gas emissions by thousands of times without compromising on patient safety. So a win-win. For example, La Paz Hospital in Madrid, just to name one example, which is one of Spain's largest pediatric hospitals, has demonstrated this potential by reducing nitrous oxide use from 2,500 tons in 2022 to just 2 tons in 2025. That's a dramatic climate win from a single change in a clinical practice. Imagine what we could achieve by bringing this up to scale. These are just a couple of promising examples that remind us that we are not starting from scratch. We have the science, we have the stories, but now we need to bring them up to scale and to do this faster, packaging them in a way that convinces governments, leaders, that investing in climate and health is not a cost, it is a return for health, for peace, for prosperity. Today we will hear 6 influential experts, each offering valuable insights and evidence on adaptation and mitigation measures that move towards net zero. They will engage in conversation with the Commission on how to respond effectively and equitably to the climate health crisis. But before we get started, it's my great privilege to introduce a leader whose vision and resolve is instrumental to this Commission journey, Dr. Hans Kluge, the Regional Director of the WHO Regional Office for Europe. Unfortunately, he cannot be with us in person this morning, but he wishes to share his message with the Commission and with all of you connecting today. Please, let's hear from Dr. Kluge. Thank you very much.
Thank you very much, Francesca. Dear Chair, Prime Minister, Katrine Jacobsdottir, colleagues and friends, first of all, I really would like to apologize for not being with you. I'm actually right now on my way to the Bled Strategic Forum in Slovenia, where we are discussing how the European region can play a stronger role in the world in the context of the humanitarian reset. I will be there with the European Commissioner Hadji Labib, responsible for the emergencies, with the President of the ICRC, with the Executive Director of the WFP, etc. And of course, as part of this humanitarian reset, this perma-crisis, the climate crisis and the importance of health, I will ensure will be front and center of the discussions. We're also focusing on how to build the resilience and work together more efficiently and effectively as we face all these connected challenges, including climate change impacting our region, which me and my family personally experienced 2 weeks ago in France, where basically we were locked down for 7 consecutive days with the heat wave, and this is not going to improve. And then when you need a general practitioner or a doctor, it becomes almost impossible in rural Dordogne because of the waiting list. So this is something that we really are facing ourselves. So building on this, I am very, very pleased to open the second hearing of this Pan-European Commission, this time with a focus on opportunities for very, very pragmatic action. Remember, we agreed on this in beautiful Reykjavik, pragmatic action to reduce health impacts of climate change in our region and beyond. And thank you again so much, Prime Minister Jacobsdottir, for receiving us, for the Minister of Health as well of Iceland, and also the Mayor of Reykjavik for an amazing kickoff of the Commission. As I was mentioning already, this summer, not only in France, but in Europe overall, we endured record-breaking heat waves, resulting in significant rise in heat-related fatalities, catastrophic wildfires, and increased mental health issues. Rare vector-borne diseases kept expanding also their foothold, and the health and emergency systems are struggling. In this context, the ruling by the International Court of Justice, affirming that states have a legal obligation to protect the environment from greenhouse gas emissions, is welcome and must act with due diligence and international cooperation to fulfill this duty. Echoing now the UN Secretary General, this is a victory for our planet, for climate justice, and for the power of young people to make a difference. Having said that, we know very well the gap between the commitment, the responsibility, and the action. Dear Chair, my friend Sir Andy, all commissioners, Your recent open letter powerfully underscored the urgency of the crisis we face and calls for decisive action. By speaking to journalists, at conferences, to the Italian media, to the Balkan media, I all followed myself, I want really to warmly thank you for proactively telling the world about this crucial work and the health impacts of climate change. This is how we ensure community health security and foster the climate resilience. This is how we shape the political discourse to drive policy change and empower leaders to make bold choices, always underpinned by science. Science, science and science. So this commission I see is our chance to turn evidence into influence, ambition into accountability, a chance to help policymakers act faster, smarter and with courage. You can count on me and I count on you. Thank you. Good luck.
Thank you, Hans. Now, I have the great honor to be joined in the studio today with the Commission's Chair, Her Excellency Katrin Jakobsdottir. Prime Minister, thank you so much, first off, for joining us today. Could you tell us briefly, what are your expectations for today's hearing?
Well, thank you, Sidika. I'm very happy that we have arrived at this point in our work and looking forward to our second hearing because Dr. Kluge mentioned our launch in Reykjavik where we diagnosed the escalating risks and threats but now we have reached the point where we are going to actively identify and unlock the opportunities for transformation, which is so badly needed. And I think, that we have reached the point where we can say that climate action can, at its best, be a very powerful driver of population health. We can see that the same policies that reduce emissions, like promoting active transport, like ensuring food security, like simply replacing fossil fuels by renewable clean energy, can actually deliver immediate health gains at the same time that they are reducing emissions. We have also been very conscious of the social dimension. Equity is a very important factor, and what we see is that, of course, climate change is affecting the vulnerable groups disproportionately. However, they are sometimes overlooked in climate adaptation and mitigation, both in planning and implementation, and this is something that we're very conscious of and will be talking about. But we also see that across the WHO European region, steps are increasingly taken to integrate health into national climate action. And this is a very positive process. We can see that good practices are demonstrating measurable benefits. But what we need to do, and this is what I hope that this Commission will deliver when we conclude our work, is that we need to assemble those best practices. We need to learn from them and share that knowledge in our continent and wider. And we need to scale them up because the urgency is great, as Dr. Kluge so accurately said in his address.
Oh, thank you so much, Chair. Without further ado, I have the privilege now of handing over to you now to introduce our first speaker.
Thank you again, Sidika. And I am thrilled to introduce Margot Wallström, who is joining us online today. Margot Wallström, a highly regarded global advocate for human rights, gender equality and environmental sustainability. She is the former Swedish Minister for Foreign Affairs, European Commissioner for the Environment and Vice President of the European Commission. She also served as the UN Special Representative on Sexual Violence and Conflict and the chair of the International Expert Panel guiding the Environment of Peace Initiative. Margot, what a pleasure to have you with us here to kickstart this hearing and hear your insights on what it takes to unlock political action. And as you are aware, the main outcome of the Commission's work is expected to be a resolute and urgent call to action on the climate crisis to protect and improve health, including both the what and the how, to government and political decision makers. Now, you, of course, have a vast experience from everything you have done really in your political career, but I specifically wanted to maybe focus on the time when you were the EU Commissioner for the Environment and ask you to tell us a little bit about your vision back then. but also reflect on what has happened since. So Margot, please tell us a little bit about that.
Thank you very much for having me. And also, first of all, congratulations and thank you to all of you commissioners, because this is absolutely crucial to recognize the link between climate change and human health. And mind you, it was 25 years ago that I took on the post as Environment Commissioner for the European Union. And of the 5 priorities that I made mine, health and the environment was one of them. Realizing that this would be difficult, because I can also say that after these 5 years, and out of the priorities that of course had to do with climate change and chemicals and the situation on water and the fact that we had a big enlargement, I felt proud over most of the things that we did, but this particular area of trying to address that huge issue of connecting climate change or environmental problems and human health I was not happy with the results, and for several reasons, because I really think that what we had to deal with was the fact that it was that we didn't have any sort of legal or institutional basis for that. So we didn't. This was not considered core business for the European Union or for the Commission. It was maybe introduced sort of too early, before people really had a proper understanding of, and political leaders had a proper understanding of what these links consisted of. And we had very little expertise. We did not have the staff to actually deal with it properly. But what we did, and where I think we did succeed, was in sort of trying to communicate or start to communicate on this. And we realized that we had to start with children and how children were affected. So we made it a point to say that, what about a 6-year-old in the different member states in the European Union? What is the life of a 6-year-old? And what kind of health challenges to their health are there? And what can we do about that? And we created kind of stories for each and every one of these 6-year-olds, including whether they could bike to school, for example. So it also had to do with safety from that point of view. And then we tried to describe what air pollution did to them, what kind of impact climate change and environmental problems had. And I think that really took off. People started to understand, well, yes, it's really about the next generation and their health and well-being. So I think that we also had enormous help from civil society, environmental organizations, and those organizations that worked on children's well-being. So maybe this is a lesson also for us today and for you as a commission. How do you engage sort of civil society properly, journalists and media, because they also have to report on these things? And it also created a perfect link to the other big issue, where I must say that I think we worked hard and that we could see tangible results, and that had to do with chemicals. This is a too long answer to your first question, Katrin, or should I should I go on and say something about chemicals as well?
Maybe follow up on what you were saying, because you said, you encountered a lot of obstacles. There was a lack of expertise. There wasn't the legal and institutional basis. But since time is short, I would like to ask you now, in 2025, when you look at the situation and the project of this commission, what obstacles do you see? And with your vast experience of administration and governance, what would your recommendations be
Yes.
for this commission? Because we are, this is kind of a narrative, as you so rightly mentioned, with the children, with the chemicals, this clear link between climate and health and environment and health. What would your recommendations be for this commission to, when it comes to the obstacles ahead of us?
Well, you entrust me with answering a question that is a big one and a difficult one. But I do believe I can say that what I did then on the chemicals issue, maybe this is part of the answer. Because I felt that when we started to create a reform for assessing the dangers with the increasing use of chemicals, then that became quickly something for the experts or the sort of the legal, those that have a legal background. It was difficult for ordinary citizens to understand what exactly did this have to do with them. And then I had a visit from a few doctors from Lancaster University in the UK, and they explained how many chemicals we have in our blood, man-made chemicals that did not exist in our grandparents' bodies. And I decided to do a blood test, and I did so and this is 2003, so it goes way back. And out of the 77 chemicals that we were looking for, I had 28 of these in my blood. And meaning also that with sort of breastfeeding my sons, this was the first gift that I gave them. And this changed the whole debate about the chemicals policy. It really created a ripple effect that made also the other environment ministers do the same tests. And it became clear to people that this affects all of us. It is in all our bodies. All these chemicals do harm, and we have to try to do something about that. I think, of course, the European Union, since then, has the Green Deal that actually also has a number of important elements and policies, the Zero Pollution Action Plan, the Environmental Action Program, also where human health and prosperity are said to be enhanced by a healthy environment, the chemical strategy, research and innovation, all of these elements that, if used correctly, can really change things around. And so I think that we have much more of a normative framework, and we need member states to implement this. And you need to reach out to citizens as well. You need to find ways to engage citizens. And I continue to think that it is through children, because that makes us think long term. Talk about how all of this will impact children. So, and involve media, get the help from civil society and all these organizations that work with these issues on the ground. But of course, you have a fantastic pool of experts. And all of you present here also in this hearing, you remain the most important pillars in all of this, because we have to rely on scientific sort of knowledge and build on that. So I wish you all the best in this. And these are only my experiences, but clearly carries both shortcomings and success.
Well, thank you, Marco, so much for sharing the wealth of your experience and providing us with the insights that you have after all that experience. And your dedication to environmental sustainability and social justice really aligns perfectly with our mission. So I am sure that we will benefit from your perspective as we continue our work towards the final call to action. So thank you so much. And I think we will bear this in mind in our work, engaging citizens, civil society, and think long term, think about the younger generation. But again, thank you so much, Marco, for joining us today.
Thank you. Thank you for inviting me.
Thank you. And And now we will continue. We have Gana Goloktianova, who is the Regional Advisor for Europe and Central Asia at the Red Cross Red Crescent Movement, Mental Health and Psychosocial Support Specialist Hub. She supports Red Cross and Red Crescent national societies in strengthening their capacity to integrate mental health into emergency response and community-based programs, addressing the psychological impacts of armed conflict, forced displacement, climate change and other emergencies. And she's with us today, and she is going to address the Commission on the role of mental health and psychosocial support in fostering community resilience to cope with and adapt to climate change. Welcome, Gana, and after your intervention we will have a short time for questions and answers from our commissioners. Please, the floor is yours.
Good morning, and thank you so much for inviting me and to the hearing and sharing the knowledge and know-how of the long period of work of the Mental Health Psychosocial Hub, but also me is here to represent and voice the work that people being volunteers of Red Cross, being members of the community, are contributing and working every day to support the communities and provide psychosocial support, which is for Red Cross is organization which is psychosocial organization by default. It's the people working to support one another in continuing to recover from the disasters and emergencies, to adapt and thrive as well. It has been, the word resilience has been mentioned almost in every other sentence in the first meeting and today as well. And we do realize, and we need to acknowledge as well, that human mental health and well-being, such as a planetary health, is in the high risk of losing the resilience as such. We need to also be understanding that we are facing the compound effects and pre-existing factors that the climate crisis deepens now, which would be the aftermath of COVID, the rising epidemiology of depression, anxiety, and suicide, the largest displacement in Europe since the World War II, driven by armed conflict. So these are not only impacting individuals, but also eroding the social fabric and especially are going in the wake of acute climate events, leaving communities more vulnerable. National societies are at the root of communities and volunteers as well, and and we know with the science that meaningful contribution to the communities through action is also contributing significantly to the well-being and mental health of people. When it comes to the movement, I'm representing Mental Health Psychosocial Hub, which is the reference center globally. There is a climate center, which is another reference center within the Red Cross and Red Crescent movement. And we are working very, very closely together on how the mental health can be integrated and linked to with the climate response. So we see and we continuously advocate about acknowledging that mental health and psychosocial support is not an addition, an add-on. It's an integral part of the community work and with the people, and that is needed from the early action to recovery. And we're working on equipping Red Cross volunteers in the skills of psychological first aid, which is helping people to recover faster and to regain the feeling of calm, safety, a sense of agency, and social connection. And Red Cross has been proven to be effective in the community-based health promotion and prevention. And during the last 3 years, the mental health psychosocial response capacity in European region has been accelerated by a large project that was aiming to support the people displaced from Ukraine and now hosted in Europe. So know-how is already there, and we, as mentioned, need to collect the best practices and to find the ways to efficiently scale up and disseminate it on the community level as well. One thing about the Red Cross to mention, which is very essential, that it's half of the volunteers globally and in European region as well are youth. And there is a Red Cross and Crescent strategy on youth-led climate action, where mental health and psychosocial support are already integrated. So with coming back to what can be done and on the solution part. As mentioned, the know-how is there. We know what is working when it comes to psychosocial support in the community. So the helping people to feel safe and facilitate creation of the safe spaces, not only in the aftermath of response to the disasters, and not only about making people feel safe physically, but also facilitating the psychological safety. And this is coming with inclusion and accessibility, and just barely facilitating places where people can talk, meet, share, because we are also discussing that the social cohesion is declining in the communities drastically. So coming up with a joint decision on how do we adapt together to the changes is vital. So practicing safety together on the household level and the community levels is important. And we know how to facilitate these processes. Emotional impacts when it comes to individuals, this is back to the basics of psychoeducation and normalizing how climate now is connected to the distress and how we can build the skills on the individual level and on the community level as well, on the group level of the joint recovery and stress management. Nature has always been a main space for people to recover from stressful events and regain the energy, and a place where people are reconnecting with themselves and with each other. It is also that these green and blue spaces, as we call them, can help people to reconnect with what they are striving and protecting, being the planet and the climate. The connected communities and sense of community connectedness is important not only for it's not only important for the recovery, but it's becoming essential for the survival itself. So it's connecting to each other, it's connecting to place, and it's connecting to the tradition. And for many, this connection has been important sense of own identity and well-being in the long run. Community leaders are having an important role. And I think this is, again, having the role and the connector roles on helping the neighbors to connect, build networks, facilitate trust locally, understanding who is the most vulnerable in the area, and making sure that they are the ones not being left behind. This is a part of, but also preparedness, but not only, it's about strengthening the community resilience as well. So this is about it, continuously engaging with the people and acknowledging that mental health and psychosocial support is not cannot be boxed and put aside like the climate change that's being discussed. Everything is becoming more interconnected and interrelated, and it's the human-centered approach that enables us to think, how can we be more efficient in the participatory, place-based and community-led action? Thank you.
Thank you so much, Gana, for this very interesting intervention. And now the floor is open for questions from commissioners. And I will begin by asking you, because you are dealing with really the mental load that comes from armed conflict, that comes from climate change, human displacement. Can you tell us a little bit, do you think these challenges, are they different, or are you using the same methods in dealing with the consequences of those challenges?
This is a very interesting question. I have mentioned that we know by far that humans have the natural path to recovery, which is being, and this is a resilience-based process. The tools and the interventions are the same. I think when we come to acknowledgement of the impact of climate change on mental health and well-being, it's understanding the diminishing resources and the repetition of the cycles, and how we can take the context of climate change, help people to connect with how they feel and what they can, using the same skills that we need to continuously disseminating. So it's the same put in the context of the climate change and equipping people with evidence-based information on how can they support themselves, how they can support each other, and making their voice heard and returning the sense of control for their lives as a recovery process. Thank you.
Thank you. Well, I have many questions coming from the commissioners, so we will have to be concrete and concise. And first is Sandrine Dixon de Cleve. Sandrine, are you there?
I am indeed. Thank you very much, Katrin, and thank you for the two excellent first testimonies. I want to come back to former Commissioner Wallström because I've very much witnessed firsthand her campaign on chemicals and how effective it was when she actually took the test, the blood test. And so, Commissioner, I'm wondering what would be the equivalence today in terms of a massive campaign that would really heighten people's awareness, but also within the Commission, as the focus very much today is actually, as you know, on competitiveness, defense, and other issues rather than deep environmental issues and also climate change. So that would be my first question. The second, with regard to the mental health impacts, to Dr. Golitsnova, what exactly could we do to also make leaders understand the risk of growing social tension and how that will also impact both their decision-making capacities, but also how that impacts the community at large? So I would love to have answers to both of those questions. Thank you very much.
Thank you, Sandrine. And the first question was very big, and we will probably be talking about that the whole day. But maybe if Ghana would like to come in now about her views on both questions, but maybe mainly the second one.
The question is very much, and we are of course following the humanitarian reset and its shifts of strategic focuses in EU in terms of resource and funding toward defense, and how we can, and thinking how we can bring up the idea of importance of strengthening and how social connectivity is related to how we will be able to protect and recover in cases of crisis. I think it's very much a fact and acknowledge that climate change and the effects also very much connected to the rises of aggression and interpersonal violence. So it's adding on to the existing polarization that is already witnessed among the people. So basically collecting these facts and making the links clearly on that remains quite a big challenge when it comes to integration of mental health, because at the end of the day, everything is impacting individuals. I think we can come up with the clear advocacy messages and show the connection, and there's an evidence behind it.
Thank you, Ghana. I think Margot Wallström is still online. Are you there, Margot? Because it would be maybe interesting to hear a little bit from you on the question from Sandrine. When it comes really to the narrative of today and what could be compatible with the chemicals that you were telling us about that were so powerful. So maybe very shortly, if you could maybe share your thoughts on that. And then I have 4 more questions, so I will have to ask everybody to be very concise.
I'll try to be short. Thank you very much for that question. That is really the most important one. What do we do now? How do we reach out? How do we mobilize? How do we anchor the decisions, the necessary decisions to deal with this? I think we need some help from behavioral scientists as well. And I remember listening to a psychologist that described the problem with climate change, because she was asking why leaders do not act on the fact that we have all the scientific evidence for climate change happening. And she said that she found that the reason is that we cannot see it as an enemy. We cannot see it as an enemy that we can fight down, because for such a long time it would happen in the future. Later on, it will happen somewhere else to somebody else. And how do we make it our own problem? And of course, now we see it has crept closer into and is disturbing our daily lives. But I return to that thinking of involving the effects on children, because that is our future. And I think this is something that also concerns everybody everywhere. And normally parents and people would care about children and their future. So maybe that could be something that could be taken up, because it forces us to think more long term. And now we act as if we know nothing about cause and effect, as if we don't have some of these answers to what has to be done. And we need to reach out with something that touches people's hearts, that they understand properly, that brings it closer home to them. So methods to do that. And I've seen that they've restarted these blood tests, actually. So my successors have restarted that, because it makes an evidence of what is going on.
Thank you so much, Margot, for your thoughts on this. Now I have a question from the Commissioner Enrico Giovannini. Enrico, you are there. Good to see you.
Thank you very much. Good morning, everybody. Yes, just going back to the reaction that I read on the media to our open letter. At least in Italy, there were some voices, typically from people who deny climate change and so on, saying, okay, now these guys want to tell us how to behave, especially in terms of health. So I think that here there is a serious issue of negative attitude to experts in terms of freedom of speech, but also freedom of behaving against the rules and Novak's movement and so on and so forth. So my question is whether there are recommendations to studies or to researches that could help the Commission to address this issue and learn from that. This is my question. Thank you.
Thank you, Enrico. Your question to Ghana. Ghana, please.
There is, of course, everything that you mentioned is already there, and what we find important, and again, this community engagement sounds the term. It's what is working. It's the supports and opinions of the peers. So how do we find people that are trusted within the community, and how we equip them with information that they can be disseminated? And at the end of the day, the research shows that the support that is efficient for the people is the peer-led support. So it's people with lived experience that have a voice, and we need to locate these people and provide the spaces for them to address. And this is where the trust is coming from. Again, taking it from the experience of advocating for rights of people with human mental health condition, that's what is working the most. So peer thinking about the modalities for the peer-led information dissemination and support strengthening, and also creating space for people with lived experience too.
Thank you, Ghana. And Sir Andrew Haynes was next on my list. Andy, are you there? Good to see you.
Thanks, Catherine. Yeah. So two very quick questions, although they could have long answers. The first one is to Margot Wallström, and you mentioned the really important obstacle of not having sufficient institutional legal basis for action to protect human health in the face of environmental changes. And I wondered what you thought of the implications of the recent ICJ ruling, and whether that opens new opportunities for action. So I'd be very interested in your views on that. The second was to Ghana, thanks to for her also very interesting presentation. And having worked at the frontline health systems for many years, I wonder what her views were about the interrelationship between these community resilience strategies and the more formal health system, particularly primary health care, which of course is fairly well established in many countries. Are there potential for synergies between community resilience building activities and the formal health system? And if so, how could we bridge that gap? Thank you.
Thank you, Andy. Margot, are you there? And the question was really on the legal basis and how recent happenings have actually influenced that. Yeah, please.
Thank you for that question, which is an excellent question and very, very important with the ICJ cases as well. And I think that we need to make sure that we refer to this, that we talk about it, that we say that this is important to have those legal bases, to have those cases that can show the world how we can look at it and create accountability. And if I just give me 30 seconds to say that I've been working for 2 years now with looking at the environmental consequences on Russia's war on Ukraine. And we wrote a report and handed it over to the president of Ukraine. And of course, they are, to raise this issue in the middle of the war, to look at how the environment is affected, is unique, historically unique. And they put a lot of emphasis on the issue of ecocide to try to get that as a fifth crime under the Rome Convention. And so I think that this is an opportunity for us to also use and widen the legal base for working on these issues. So I put a lot of importance to that, for sure.
Thank you, Margot. And then I pass the floor to Ghana for the second question from Sir Andrew.
Thank you so much for the question. And this is a very important one. And of course, primary health care that is based in the community has a very, very important role to play because they are a part of the community. So all of the work that has been taking place in the region through the past 10 years about integrating mental health and the primary health just needs to be continued, scaled up, adding on the equipping primary healthcare practitioners with the more clear understanding on the links between the climate-induced changes and the mental health and psychosocial well-being. And another one is more community-based coordination and connectivity. So it's how do we connect primary health care with the social care and education, acknowledging, again, it's multi-sectorial and cross-cutting, and this needs to be addressed altogether. So two things: continue integrate mental health on the primary health care, connecting, and multi-sectorial collaboration.
Thank you, Ghana. I have two more commissioners with questions. Linda Bregu. Linda, please. Good to see you.
Hi, good morning to everyone. Just two quick questions. One to Commissioner Wallström. So you mentioned and said clearly that there is a big difference from the times when you were a commissioner and the times we are living in. So there is a legal basis today in place. That is the good news. Enough funds are never in place, but as well as we know that laws are implementable and are successful as long as those are implementable. So considering your experience, apart from the legal basis and being a former politician, what do you feel is missing these days in the implementation of the Green Deal and the legal basis? And so what would you like to hear if you were a politician today from us and everybody else to see an action in the story? And the second question to Ghana. I've been quite fond in trying to relate the climate change, the crisis, and the mental health. But while we are trying to measure the health benefits or the problems coming related to mental health, do we have indicators the right ones that can really convince the policymakers on making the connection between the climate change, the stress, anxiety, and so on, and the mental health? So do we really have the right indicators?
Great questions. I will ask both Marco and Ghana to be very concise. Marco, if you would like to answer the first question.
Yeah, I see that there is a backlash today in both against the Green Deal. And of course, these are economic interests speaking. Follow the money, and you will see also where the resistance comes from. And what they call simplification is, in fact, seems to be, in fact, a sort of tearing down of some of the basic elements also in the REACH legislation. So, of course, we live in times where there is a militarization, where money is going into that instead to weapons, instead of being used, for example, to fight the effects of climate change. So this will be a matter of fighting for enough of resources. I think most of the legal basis is there, but as you said, a legal act is only as good as its implementation. But we do have the right words in place, the right goals, and we just have to make sure that politicians also act upon this, and we have to make it as concrete as possible. And we have seen now the real effects and things that we talked about 25 years ago as the things that we never thought would appear, like the melting of the permafrost, is now a reality. And we were saying then this will not happen. That is just then it has gone too far. And now this is happening daily. But we have to fight on, that's for sure. And we have to find the ways to reach to people's and engage citizens in that and say that we ask you to do this. And why not through children and young people? It's their future that we are now destroying.
Thank you, Marco, so much for that answer. And Ghana, please.
I think one point, which is important one, is this whole discussion about the social determinants of health. Right now, we are adding on the climate determinants of health, and how we can define those criteria into connecting them with mental health is a challenge. And this is another point that is important to consider, to investing more into the research, but also including these elements of the prolonged distress, cumulative stress, and implication also on mental health, which with the focus on the climate determinants. I think that's the solution, but we need to broaden the research base and understand that it's a compound effect.
Thank you, Ghana. And then a final question from Hans Brunix. Hans, please, good to see you.
Yes, good to see you all. Good morning, and thank you for the two introductions. My first question is building on the last intervention by Margot Wallström. We do indeed have the legal basis, and if it's not there, that is exactly the role of politicians, because we cannot change the laws of physics, but we can change the laws that we create, and that's what policy making is, of course, all about. Now, most of the legal basis is there, I would agree, in the Green Deal and in the climate and climate adaptation packages that are out there. But if you look at the cynicism and the complete neglect of the connection that we are discussing today with a rather large part of the politicians in Europe today, it seems like they don't care. They don't care at all about these issues. They care about other issues. So in your experience, having been a part of another issue where people didn't necessarily care, what would be a critical element of making top politicians go back to where we were just a couple of years ago with the Green Deal? And that connects to Ghana's intervention. You talk a lot about community leadership, but how do you organize community leadership when national leadership is failing in so many ways on the issue that we are discussing? And should we maybe focus more on organization and pressure from below? Because at the end of the day, it's pressure from below that is the energy of social movements, and that is putting pressure on politicians because they need to get elected to be a politician. So organization and pressure from below, and how can we make them care? Because my feeling is that they don't care at all at this moment, which is bizarre if you look at the last summer with the fires and the heat waves and all the implications for health.
Thank you, Hans. Thank you so much. Two very big questions, and sadly I will have to ask you to be very short in your answers. And Margot, if you would begin.
I understand this is a commission where you will never get any easy questions to answer. Well, this is the thing. This is why I return to what is it that can really swing people in the right direction. It is, of course, when reality hits, when you can see that this is true. All the effects that they said would come from climate change is now hitting us as well. The heat waves, the extreme weather conditions that we see. Experts have told us that for decades now, for a very, very long time. And now it's hitting home. But we need to reach out to think long term. I return to that. I think health, people care about their health. So the health is the argument that must absolutely be used. And also the try to inject this feeling of having a responsibility also for the new generations, for children and young people. They want to live. They want to have a life.
Thank you so much, Margot. And Ghana, a final answer.
Very much supporting on the need that we need to activate the work bottom up. And because the community leaders are the ones responding and seeing the consequences with the life examples. So it comes to making their voice stronger. Another thing is that we are trying to change the system on the system level, whereas the know-how, the evidence, and resources accumulated on the system level, but not necessarily going on the community level. And so we need to be, at least for the tools, knowledge, information, be more proactive and get it to the people on the community level. And I think this will help them to strengthen their voice and get more into the active places of decision making on the early action protocols, on and other potential programming that will help to change the system levels. So that is my solution and a call for us to continue our work.
Thank you so much, both Margot and Ghana, for your answers to not too easy questions. But now we will move on to our next expert. Maria Gallen is a member of the European Board of Directors at Health Care Without Harm, a non-profit organization working to transform the healthcare sector so that it reduces its environmental footprint, becomes more resilient, and establishes itself as a leader for sustainable development in Europe. And Maria is also the initiator, former leader, and now Chief of Development at the Center for Sustainable Hospitals, Central Region Denmark, and board member at Green Transition Denmark. And today she will speak to us on the role of the health sector in tackling climate change, in particular successful initiatives in building climate resilient health sectors in the WHO European region. So welcome, Maria.
Thank you so much, Jen. Thank you to the whole Commission for the invitation. I am honored to be speaking on behalf of the European Board of Directors at Healthcare Without Harm Europe. I have a background as a midwife, and I have nearly 10 years of clinical experience myself, and the journey into working full-time with this green transition of healthcare for me started with a frustration witnessing the consumption of single-use materials on my daily work. And I will now share the screen because I share this frustration with a woman who was a patient and who is also an artist. That is Maria Kujik, a Dutch artist. And what you hopefully see on the screen now is on the left, all the single-use consumption that was used during her own surgery for breast cancer. And on the left, there is a picture of single-use equipment used from an uncomplicated, normal hospital birth in the Netherlands. Now, this visualization shows, of course, that there is a climate impact from the consumption from healthcare. What it also shows indirectly, not so visible, is that there is an environmental and directly negative impact on the health of people, since many of these products reveal microplastics and chemistry is involved. For instance, the gowns you see in the picture on the left are covered in PFAS. Many of the tubes and other plastic products used within healthcare contains PVC, and both chemicals are on the phase-out list in the European Union, but are still being used every day directly in the treatment of patients. What this picture also shows, which is connected to resilience, is a vulnerability. If you try to mentally zoom out and imagine a floor that would be big enough to take all the single-use equipment needed to run the hospitals all over Europe operational for just one day shift, the amount would be striking and would reveal the climate impact, yes, but it would also reveal a vulnerability to these complex global supply chains that we are depending on in order to perform the procedures needed to produce health for the European population. These pictures, of course, also shows very good intentions, the result of research and evidence-based practice trying to reduce the risk of infection and trying to do everything as good as possible. But we're looking at a paradox where the intention and the purpose of healthcare consumption have a backside that is counterintuitive and that threatens human health, not just in Europe, but on a global scale. Now, if we look at the data, we know from a report produced by Healthcare Without Harm, and which was proven by the Lancet Countdown in 2023, that estimates point at the global healthcare system being responsible for about 4.4% of global CO2 emissions. In Denmark, where I come from, healthcare is responsible for around 6% of the national emissions, where in India it's only 1.5%. USA is at the top with 7.6% of national emissions. So what we see is a picture where the most developed healthcare system in the high-income countries have a much larger emission than in lower and middle-income countries. About 70% of the CO2 emission from most European healthcare system comes from scope 3. The highest emission is connected to a consumption of medicine and med tech equipment. At the same time, BNP in low and middle income countries are rising. Thousands of hospitals are being built. And of course, more health for more people is a global goal. But if we simply scale up the consumption you saw in the pictures, the global emission from healthcare will be rising as will the request for all these products. And that will mean probably a rise in price and a decrease in availability as well, especially in unsecure geopolitical situations. And climate change is predicted to create disturbances throughout the whole production line and the logistics. So to have a European healthcare system that is continually depending on daily deliverances of single-use equipment made of limited, non-renewable raw materials in the global situation we're facing right now, that is not sustainable healthcare, and that is not a resilient healthcare system. So the good news is that there are things we can do to improve the situation. And on behalf of the European Board of Directors of Healthcare Without Harm, I would like to suggest the Commission 3 points of action. The first one has already been mentioned. It is to mandate the development and implementation of national climate resilience strategies. We are the fastest warming continent on Earth, as said during the first hearing multiple times, and the first ever European agency's climate risk assessment, EUCRA, from 24 clearly states that we're not ready. Commitments have been made in the Budapest Declaration and the attach, but still it's not all countries that have produced dedicated adaptation or climate action plans. Healthcare Without Harm have supported some countries with the development of roadmaps to net zero, and we acknowledge that there is an increasing attention and also high-level political commitments to this area, both decarbonization and the adaptation. But there is a critical gap between the intention and the strategies, and then the number and the quality of the actual implementation. So a national adaptation plan, including plans for implementation and adequate resourcing, is a necessity in every European country. Now, the second point of action we would like to suggest is to address these Scope 3 emissions. They are our biggest problem, and we need to use less to have a more circular consumption and to decarbonize and build resilience throughout the global supply chain. Obviously, prevention is the point where we use less since treatment is never necessary. It is without my and Healthcare Without Harm's field of expertise, so I will not dive into it, but I would just like to show our support to the points made during the first hearing that prevention is an absolute necessity to have a sustainable, resilient healthcare system. Choosing Wisely is a framework that is a very potent initiative. It is driven by healthcare professionals, and they are working to minimize low-value care. The driver is not climate within this framework, but it's an example of how to make a reduction in low-value care and doing less can benefit both people, profit, and planet. And this initiative should be spread out and scaled out through Europe. Now, of course, sometimes choosing wisely is also to actually perform a treatment or an operation. And in those cases, we need to use wisely. Moving from single use to multiple use is a very potent area. Not in all cases the right decision, but in many. And I would like to show you some examples. These are metal instruments made of surgical steel, and these are all single-used. Of course, there is a multiple-use version available on the market, and we have shown in different pilot studies that there is a big CO2 reduction to be found when switching to multiple-use instruments, in some cases up to 90%, and also positive business cases. And we could ask ourselves, should it be legal to use single-use surgical steel every day in numbers of millions of instruments in European hospitals when we are not allowed to use single-use plastic straws for our patients in bed? For more complicated equipment, it could be something like this, also a single-use piece of equipment, and this one as well. And for now, the incitement structures on both a political, financial, and practical level are supporting single-use production and consumption. Though reprocessing and multiple-use versions is often possible, not always, but in several cases, and the calculations shows also significant CO2 reductions and financial savings. And I would like to underscore that the industry is our partners in this matter. This is a transformation on a systemic level. And MedTech Europe is actually represented by the CEO in the board of Healthcare Without Harm Europe. But we need together more support politically and financially to make this fundamental market transition from a linear consumption to a circular consumption within European healthcare. Now, finally, we need a focus on the whole global healthcare supply chain and work strategically, of course, with our procurement criteria. We need to demand, assess, and reward the suppliers throughout the value chain for climate, environmental, and also social sustainability criteria. We need to prioritize reusability, repairability, and durability. We need to explore new business models, and new business opportunities could be in relation to the reprocessing I just showed you. And on top of that, we need to standardize the way we do it, because these global companies cannot deal with confusing and time-consuming regional or national variation in the demands within tenders. We need standardization, and we need transparency between healthcare system and providers in order to make the transformation. We have concrete examples of some of these actions that are feasible and scalable, and we would, of course, love to share them with you. Now, the last point of action is to educate and empower healthcare professionals as agents of change. It has been said today, it has been said on the first hearing as well, that we need a cultural change, we need a social movement to make this happen. And if we need to explore and innovate and implement different ways of consuming in clinical settings for inspiration for the whole society, it simply cannot be done without the engagement of our clinical staff and the healthcare leaders. So we need this whole area of climate, health, and healthcare resilience embedded in the curriculum on every healthcare education. We need organizational structures within healthcare, and ministries of health and governments have a vital role to ensure that every healthcare facility builds up an organizational structure, just like we have with work environmental issue. That's not just a free choice, it's a legal demand that you have someone responsible for taking care of this area. And on the first hearing, Louise and Neubert talked about change agents, and I would like to say that healthcare professionals are actually among some of the most trusted voices in society in many European countries. And these voices could be used in national awareness campaign and to inspire for healthier lifestyles and healthier, more circular ways of consumption. Because the way we consume our big bins are seen by the patients, as the picture by the artist Maria Kojic showed in the beginning. So just to sum up, investing in a sustainable and resilient healthcare system through both mitigation and adaptation, it's not just the moral or ethical obligations we have on environmental imperative to protect the earth. It is a necessity to safeguard the public health in Europe and securing a healthcare sector that is capable of performing what is needed when it is needed. And the level of complexity is high. The incitement structures right now is not where we could wish it to be, and the power within the market and the whole culture is so strong it can have an almost paralyzing effect. But there are things we can do right now, and the current level of attention and resources falls far short of what is needed. So we need to shift our approach from reactive responses to this proactive and preventive preparedness. And healthcare without harm would, of course, like to offer our and our members expertise in any collaborative ways. We've been working in 30 years with this area within the whole range of what I've talked about today, from policy to practical level. So the core message is clear. If we look at the global political picture right now and the climate change, the European health sector can and must become a proactive leader on a globally scale to build up a holistic, sustainable and resilient healthcare system by embracing the fact that mitigation and resilience are two sides of the same coin. Europe's healthcare system can make a big change, not only for health and resilience in Europe, but globally. Thank you.
Thank you so much, Maria. Thank you for really drawing that picture for us, because I'm not sure that everybody is really aware of the climate impact of the health sector, but also showing us that there are many steps that can be taken to reduce emissions and making the health system more sustainable. Now, I have already several commissioners asking questions, and again, we need to be very concise to stay on time. And Connie Hedegaard, are you there? Yes, good to see you, Connie. You're first.
Same to you, Catherine. And Maria, thank you for a really excellent presentation. And I like very much you are suggesting a lot of very concrete recommendations, exactly what we are looking for. But just two follow-up questions. The one related, your example, for instance, with the single-use steel instruments, and that could be multiple use. linked to public procurement requirements. The reason why things as you describe it, I mean, it's common sense. What are the real barriers? Is it cost or is it also safety? Just if you could expand a bit on that. And the other thing is the mental stress that people exposed to climate change, to floodings time and again in your family house and all this. Do you in your different projects, do we really have enough knowledge to quantify and qualify whatever we could say on that? I would like to hear your comment on that.
Thank you, Connie. Maria, please, if we could hear your thoughts on that.
Yes, thank you for two excellent questions. Now, starting with the metal instruments, the reason why we, during the last decade, switched from multiple use, because that was the original products, to single use, especially happened during the HIV period. And as a response to an infection that was completely out of our hands and that made people scared, basically. But today, there are no safety issues switching from single use back to multiple use. In most hospitals, you have a sterilization department. So the real reason why we are not just doing this, because you're right, it's common sense. We have several business case examples showing that this is possible, this is patient safe, it is everything you could ask for. The quality is even better. It's much nicer to work with as a professional clinician. But the logistics in modern hospitals are not made for multiple use instruments. We have minimized our sterile departments in so many hospitals that it's hard to keep up with the production if we should make big switches. But we have made cases, and right now in the central Denmark region, we have actually managed to reduce the consumption of single-use metal instruments with 40%, and we have put up a strategic goal saying we want to reduce it with 75% by the end of 26, and that should be possible. But logistics is a challenge. And the second question is to the mental stress. It is not my field of expertise, so I'm not completely familiar with the research on the area, but from what I hear from colleagues, then no, there's still a research gap. And what I sense when I work around in the hospitals and in Denmark and talk to people all over Europe, it is an issue that is rising, and it is rising also among the healthcare professionals who have a double role. They are facing it as normal citizens, striking themselves and their own health, but also how are they supposed to manage this in their work time if the whole burden of diseases picture will change and be more complex, and at the same time we will be lacking different products and so on. So yeah, that was a bit unclear answer. And the last one, I apologize for that, but it was the best I could do.
Well, thank you, Maria. I have 3 more commissioners asking for the floor, and Ernst Kuipers is next. Ernst, are you there?
Yes, I am. Thank you very much.
Good
and
to
thank
see
you very
you.
much, Maria, for a very, very clear call to action. Also showing us many examples. And we do, of course, know that if you could easily go on for another hour or 2 hours and give us many more, both in transport and logistics and so on and so on. Now, we know examples, amongst others, from the Netherlands, where we have done the measurements and know that the largest healthcare providers have an impact and, for instance, have on an annual basis, have more than 200,000 tons of carbon dioxide alone as one single provider. And some of those have actually already done the math and really put it down to every individual action at a department level. Now, my question, with your background and be closely involved in the healthcare without harm, do you think that we would be ready to actually put individual targets and like both measurements to healthcare providers, but also then combine that with targets, what to achieve in terms of reduction of footprint in the coming years? So making it very, very measurable and also actionable. Do you think that we are there?
Maria, please, the floor is yours.
Very short answer, yes, we are, because we have to be. And of course, there are still data that is not precise, and there are, like I said, a need for further standardization of the methodology on how do we calculate, because if a global provider comes with a product and say, this is the CO2 emission from this product, we did an LCA, then we don't really know how they did it and if we approve on the method. And there's still a lot of things there that we need to align in order to gain higher quality, efficiency, and trust.
Yeah.
But we must not let that stop us. Sending a clear demand throughout the supply chain to decarbonize and to deliver data on this area is a first very important step and signal to say that we are serious about this. And the NHS has done it. They have been a very clear example on how to put up these demands, and apparently that seems to have a very positive effect on the whole global market. So we should follow their example.
Great,
Wonderful.
thank you. Thank you, Maria. 2 more questions. Enrico Giovannini has a question. Please, Enrico.
Thank you very much. The first question is about the single-use, multiple-use. Do you have a sort of map at European level, pan-European level, on where are the strongest negative reactions or resistances, and where there is a more positive attitude? And the second question is not really to you, but is to WHO colleagues, is about Africa. As we know, Africa skipped a sort of generation of telephones, moving immediately towards the mobile phones. And we know that the demographic trends in Africa will make extremely important for the entire world the consumption of materials that Africa will have. Is there any push to have a multiple-use culture in Africa beside what happens in the pan-European region? Thank you.
Thank you, Enrico. Maria, please.
That's a good question. And no, we do not have a complete mapping of it, but we do have the most concrete example we have is that in the MDR Convention in Chapter 17, Piece 3, it's possible for a country to allow reprocessing of complicated medical equipment during under certain circumstances. Like the ones I showed you, you can actually sterilize and certify and use again. Now, we do have a mapping over which countries have said, yes, we will allow that in our country, or we will not allow it. And some countries saying we will allow it within these parts of healthcare, these types of surgery, and which one we won't. So that is a picture saying that we're definitely not united in Europe according to what are we positive on doing and what are we more negative in regard to actually start to implement. I think, but let me look at it and see if we have different lists of products and things that are being done, projects. Maybe something could be extracted from that, but it varies.
Thank you, Maria. Your question, Enrico, on Africa is really good, but I think we will have to take some time later to talk about that, because we need more time to do that. And I have one more question for Maria from Sir Andrew. So please, and again, I ask everybody to be very short and concise.
I wanted to sort of take a slightly different angle to the question that Enrico asked, because you mentioned that other parts of the world could learn from what Europe's doing, but I'd like to suggest that maybe Europe can also learn from what other parts of the world are doing, because one example is the Aravind Eye Care Service. So their cataract surgery has a few % of the environmental impact of cataract surgery in the USA and in Europe. So shouldn't we be looking to others around the world who are actually innovating in a very low environmental impact way, but also delivering extremely high quality care? So that's one question. The second is a big question, but perhaps you can have a short answer. And that is, you also mentioned that Healthcare Without Harm aspires to influence sustainable development policy more generally in Europe, which I presume means working with other sectors. So I wonder if you could say just a few words about how you see the healthcare sector influencing other sectors or working with other sectors to promote a more sustainable and healthier economy. Thank you.
Thank you, Andy. And Maria, this was the final question, and both of them obviously require long answers, but I will still ask you to be short.
I'll do my best. Yes, we definitely need to look at how they're doing it in other countries where this frugal innovation, you could say, is very inspiring, and we are doing so. And we have found big differences inside regions of Europe where two hospitals perform the same procedure with up to 40% differences in the weight of the total consumption of single use. So just looking at how we are doing things, being inspired by others who can do the same procedures, perform the same procedures with the same outcome, using less, is a very potent area, and we are definitely looking into that. The way we inspire other sectors, I think that is really an area that should be explored more and cultivated upon, because there is big coherences between the whole social area, the mental and the physical area, just to start somewhere, and this whole lifestyle transition that is part of the sustainable transition and prevention agenda as well. It has been mentioned today that taking the bike, eating healthy has an impact on health, on emissions, on air pollutions, on so many areas. So working in these cross-disciplinary areas is something we need to do much more, and we would happily be invited and contribute to wherever we can.
Thank you, Maria, and I am sure that we will contact you again to help us in our work in the upcoming weeks and months. So thank you again. But we will now move on to our next speaker, who is Professor Igor Spirovsky, Head of Division of Environmental Health, Institute of Public Health, Republic of North Macedonia. Professor Igor Spirovsky is a professor of environmental health and public health nutrition at the Faculty of Medicine of the St. Cyril and Methodius University in Skopje, North Macedonia. Professor Igor led the team that prepared the updated version of the action plan for preventing the consequences of heat waves to the health of the population in the Republic of North Macedonia for the years 2025 to 2030. And today he's going to share with us lessons learned from North Macedonia's National Action Plan on Heat Health, which is a very relevant topic after the summer here in Europe. So welcome, Professor Igor.
Thank you, Madam Chair, respected commissioners, colleagues. Thank you for inviting me to be part of this hearing and to share, as the title of my presentation says, to share a few lessons learned about the implementation of our National Heat Action Plan. I would try to be on time. I'm sure I will. I'll have a few focus about the content, then about the lessons learned, and about a few questions that I would like to focus on during my presentations. Of course, this plan is comprehensive updated document. Why updated? I'll say a few words later. Regarding its context, it includes the definition of key aspects about the risk management, particularly risk management from heat waves for the vulnerable populations, the sole identification of those vulnerable populations. Of course, the plan focuses on improving the response of the health system regarding the heat waves, not only in the health, not only the sole health system, but also the education and social care system. It goes all the way to the urban planning and green spaces, green housing, something that can add to the prevention of the heat waves for our population. It has separate parts about the information and communication regarding the protection of the population of the heat waves. That starts with the microclimate conditions, how to avoid heat, how to help people who need help from heat waves or from heat in general, etc. It goes also to the food safety and water safety, which are crucial. This action plan is unique about inclusion, the monitoring and evaluation protocols, particularly for hospitals, it has some indicators regarding that, and also has some protocols for specific institutions. Those institutions are the centers of public health, which are in North Macedonia, 10 around the country, special protocol for health and education institutions, for the Ministry of Health, and for the Institute of Public Health. It also includes 13 appendixes for specific cases, if possible, if applicable. Sorry. I'll now just share one slide regarding of how this plan looks. This is our action plan, which is here, and on the next slide that I will share, this is in fact the decision and the adoption done by the government of my country at the end of April, which was quite timely, just before the starting of the implementation of this action plan, which starts every year on May 1st and ends on September 30th. I'll stop sharing now. Is this okay now, or? Yeah, okay, that's fine. So first question that I would like to focus is the critical steps in advancing interventions on climate change and health at the national level. How did the health sector positioned as a central actor of this process? The key point is that, of course, this plan didn't came out of the blue. I mentioned that this is updated action plan, so it means that this type of action plan already existed, and I'm proud that my country is probably one of the first countries in Europe or WHO, a European region, that has adopted this type of plan back in 2011. So the first plan was there since 2011. Of course, it relied on a focus on climate change by several researchers and scientists, faculty personnel, who was trying to put on a higher level the importance of the climate change and the heat waves as a separate part of those processes. At that time, it was quite early in my career, of course, and I was following that process. That was quite novelty in North Macedonia. WHO Europe, of course, used that plan in 2011 as a showcase about the assessment of costs regarding the heat waves, and it was a pilot tested through the WHO tool, and there is a publication regarding this. It was so already the process of implementation started in my country, and it wasn't completely new process, but this updated process needed the health sector to take advantage and to be the first one that can take the critical steps regarding the interventions. Of course, how the health sector could and did that. Unfortunately, it was not, let's say, the systematic issue, but mostly it was the process as the plan in 2011. It was the case of motivated individuals. We are lucky that motivated individuals in the health sector and in the Ministry of Health, of course, in the Institute of Public Health of my institution, are probably more vocal than the individuals in other sectors. So this sector took the flag and convened the message and acceptance of the importance of this type of actions. Of course, I would like to mention now, probably I'll mention it once again, the very active position from the WHO country office in North Macedonia. This country office is very active regarding this issue and others, and they were pushing through the Ministry of Health as a primary counterpart. They were pushing this process, and the importance of the WHO, as I said, I will mention it later, is very, very, very crucial. One other thing why this action plan was present everywhere this spring was a type of controversy. Probably this type of controversy is sometimes needed if you want to put something under spotlight. And this, I would say, controversy, which was not a real controversy, is that comparing to the previous action plan, there was a change. In fact, the lowering of the threshold temperatures to announce yellow, orange on the red alerts, because we have a color code on those. So the National Meteorological Service did that because they compared 30 or 40 years of measuring of temperatures by months, and they did some standard deviation and medians regarding that. So their conclusion during the process of preparation of this plan was to lower the temperatures. So we were expecting by this lowering of those temperatures that we were expecting that we will have, in fact, more frequent heat waves, which this year didn't quite show like that. The other issue that I want to say a few words about is how this national plan ensures that the most vulnerable communities will be reached and empowered through a bottom-up community-driven approach. We tried to have a quite multi-sectoral composition of working group that was preparing this plan. Key sectors were covering, of course, and participants were covering most affected populations. So, of course, those were the open-air workers, the elderly, the homeless, people living with chronic conditions, elderly, as I mentioned before, and people living with with overweight and obesity also as a chronic population, which was kind of a novelty in this action plan. So covering those populations, there was a representativeness of patient associations also. So there was a representative of quite a range of communities that can be reached. Of course, the health sector coordinated this process about the universal entry point of health as a most important achievement, maintaining healthy as a most important achievement. So that was the one thing that was crucial for the health sector to move the process forward. We made partnerships with the NGOs, of course, especially I'm happy that the representative of the Red Cross and Red Crescent international organizations is here present, because our partnership with Red Cross was crucial also during this process because of their reach to the most affected community, particularly the homeless and people with low social, from a lower, let's say, social background. So really a big comment to the Red Cross and their involvement and their continuous presence during the implementation of this action plan. The other institution was the Authority for Crisis Management. They were also some those that can have a bigger reach towards the vulnerable populations. And I would like to stress this again, the partnership with, I would call it the overall coordinator, like WHO is, because of the high respect that this organization has, and the government is still seeing the WHO as a really crucial partner when doing this kind of national documents that will and should be accepted by the wider community and by the other policymakers, because the Ministry of Health is not the only one, of course, is the leading one, but the environment sector, of course, has legally obligations regarding the climate change and the heat waves. I would conclude maybe with the last thing that I want to say a few words about, and those are some recommendations or some experiences from our implementation that we can recommend to the Commission and maybe to the governments, who are involved in this process. One of those which I think is the most important is that this plan and this type of activity should be a living, let's say, priority through two processes. One is process of presence, and the other one is the process of partnerships. Presence is the communication with the populations and with the media. I would share a slide at the end of my presentation that general population in North Macedonia is quite sensitized and had their thoughts regarding this, the heat as a problem, and because we are, as you know, in south of Europe and we experience heat days and heat waves probably very frequently. So the presence through the population, and the population is talking about this action plan because they now know, because we are following the process of implementation for many years, that this thing is there, is present, and their government is doing, and in thinking about this heat as a health problem, which is quite novel approach because heat was considered something normal, but we never had enough data to show that it is in fact health problem. The partnership with the media are quite interesting. I can witness from my experience and from experience of what was happening in previous years that the media are very interested of what's going on and what the government is doing regarding this, and the Ministry of Health, of course. And the partnerships with all the stakeholders in the society. I would say that the message would be to avoid being seen as the enemy. Why the enemy? Because some of the especially the sector of the economy, the sector of construction, would see our recommendations and some kind of objections of their work, especially in the summer when it's their season to build and to make some profits, I would say. But I think that we managed to do a good job regarding that, and the first attacks that were there regarding our let's say being bad people who are recommending avoiding work at extreme heat, etc. So making something about their profits. Now with the communication with them, we see that this thing is not happening, and the economy is seeing that the heat waves, these things can be overcome with appropriate measures from their side. So I would close at this point. I would just share the things regarding share a slide regarding the presence and the partnership part. This is the extract from the government website. One case of proclamation of phase 3. So the red alert that happened sometimes in June. Yes, it's 24th of June 2025, and the measures from the plan should be implemented. This is from the government website, and the other things is the website from our news, not one, this one, from our news and the media. So these are only a few news regarding the action, the measures and the coverage regarding our national heat action plan and the recommendations, reciting the plan and citing the institutions that should do their work regarding the heat action plan. So this presence and these partnerships, I think, are crucial, and maybe the recommendation then should be a takeaway from this my presentation. Thank you.
Thank you, Igor. Thank you so much. We already have some commissioners with questions, but very important points you made there about, for example, the inclusion of vulnerable groups, both in the planning and the implementation, but also the partnerships that were key to that. So, but I have first here on my list, Katuna Gogaladze. Katuna, are you there? Good to see you.
Hello, everyone again. Thank you, Chair, and many thanks to Dr. Spiroski for sharing experience about North Macedonia, about this action plan. And I have two questions. One is about the first plan, which you remember, you mentioned that, if I remember correctly, it was adopted in 2011. So it means that it was already implemented and you have some results from that plan. So my first question is about that plan. Could you share some good examples about actions? Which actions have HCs for our recommendations? I mean, in other words, what worked and what did not work, or what kind of actions worked and what did not work, and what were the reasons? This is maybe a little bit big question. And another one is much shorter, about the second action plan, which was approved this year, as far as I understood. What's the budget of this action plan for the implementation of this plan? Thank you.
Okay, Igor, what worked and what didn't work, and what was the budget? $1 million question.
The main things and the most important things that work is the involvement of all the sectors. Because this was seen previously in, I'm talking now back in 2010, 2009, 10, when these things was starting to roll, it was seen as something that had to be done by the health sector. But what worked, the main point, I think, from the implementation of that previous action plan is that all the stakeholders were there, and now we saw that when we prepared this updated action plan, we saw that all the institutions out of the health sector were keen to participate and to be part, to have their role in the process of adopting and implementation of this action plan, which this updated action plan. What didn't work, as we cannot clearly assess the impact. So the monitoring and evaluation was not at the level that we wanted to be. So that's why we focused a special chapter, special part of this plan to the monitoring and evaluation. And I think that after this season of heat, which will end at the end of this month, we'll start to see how what was the impact and what was the involvement of the stakeholders during this action plan. Regarding the budget, there is no particular fiscal implication regarding this. All the institutions in their work, in their budgets of their institutions should work for implementation of this heat action plan. So there is not particular budget allocated from the government for the implementation of this action plan. It relies to the budget of the institutions, which I'm not aware if they have a separate budget inside the institution for this action plan. Of course, there are from some other stakeholders. I'm talking about the government institution. The other stakeholders which are providing some measurable, let's say, fiscal implications, like the Red Cross and some other NGOs, they certainly have their specific allocated budgets for the assistance on the implementation.
Thank you, Igor. I have some more questions for you. And again, I will ask everybody to be very concrete and concise and short. And Sir Andrew, you're next.
Well,
actually, my question was going to be about evaluation, because what we're finding is there's a lot of adaptation projects around the world, and yet it's quite difficult to get an assessment of which ones are really effective and which ones are not, based on, because people are not actually monitoring the impact on some of the key outcomes like deaths, for example, during heat events. So I just wondered if you could say a bit more about what your plans are to improve the evaluation of what you're doing. My second point is a very specific one about the construction sector. And I was very interested to hear how you're working with them. But I think there's also an opportunity, because the construction sector we're finding is still building buildings which are not heat resilient. In the UK even, we have complaints that many modern apartments are actually exposing people to extraordinarily high levels of heat because they're designed for the previous era when cold was a problem and heat wasn't. So I wonder if there's an opportunity for you to work with the construction sector to actually improve the design and the construction of modern buildings to make them more heat resilient and not requiring vast amounts of air conditioning, which is what's happening at the moment. Poorly designed buildings, and then you have to stick in air conditioning. Thank you.
Thank you, Andy. Igor, can you comment on that?
Yes, thank you. Great suggestions, and I'm happy that we were foreseeing something regarding the evaluation. I cannot speak about the results of our evaluation because it didn't start it. We extensively talked with the hospitals, with emergency healthcare services to clearly note their calls and how they can, how and if they can, because it's not that easy. If you have a chronic patient and see that some situation is going on during the heat wave, it's not straightforward that you can associate that with all medical doctors will agree with me that it's not straightforward that is associated really with the heat. But for those who are sure that are associated with the heat, we have started to get some of their reports, and we are putting them together to see if there was a change from the previous years. And this is only one part. We have some other indicators also. Regarding the construction sector, yes, I think we have some level of communication, particularly from the Institute of Occupational Health, who are part of this process, and they are quite proactive. They have some connections with a few NGOs that work with the construction sector. But I agree, this should be an opportunity of not rely on air conditioning, and I'm not aware if, of course, there is some thoughts, as you said, that heat resilient building is not is under scrutiny now. We were more. There is a huge highway constructions going on around the country now, and we were particularly concerned about those people, and we were contacting those building providers who are working on those highways, and we had a few communications with them regarding this. So it's not only apartment building, but also construction
sector. Thank you so much, Igor. I have two more commissioners with questions, and I'm going to take them together, so just note down their questions. First is Majlinda Bregu. Majlinda, please.
Igor, zdravo. So me and you are the only ones from Balkans today, and that's why you might feel that I have some questions that will really relate close to you. So you mentioned something really important, which is quite a cultural, let's say, or a pattern in the Western Balkans, which is considering the other as the enemy. Like the one that is proposing you some changes that will move you out of the comfort zone. And taking into consideration that the public trust in our region, in the Balkan countries, into the government is not like overflowing, how have you foreseen like to flip the script? So I'm referring to what you said on the workers. So if you are saying to somebody, a businessman, the ones who are constructing every day is the only business flourishing in our region mostly, that your workers should not work and you should limit their work during the peak of the heat waves. Do you think that the action plan can convince them? So has the government, or in the action plan, have you foreseen any financial incentives or wage protection that can convince the business community to follow this script? The second question, but I think that you already started to give the answer through the question of Sir Andrew. How have you envisaged that you will track the outcomes? So are you preparing recommendations for hospitalization, for mortality, heat-related cases, or awareness campaign among doctors and nurses and so on? And the third, the very short answer from yourself. What is your experience, and are you in touch with your colleagues from other countries in the Balkans?
Great. 3 questions from Linda, and I will now move to Ernst Coopers with the last question, and I hope you're noting everything down, Igor. But Ernst, please.
Yeah, thank you very much, and very good to combine the questions, because I actually had a question which is on exactly the same line. So the topic of the hearing today is about opportunities and potential benefits of climate action on our health. When you mention it's important not to be seen as, what you said, the enemy, my question was, did you or can you bring it to a next level and actually be seen with your plan as a trusted partner, a partner which is timely and in advance being sought for advice, for help with action or with monitoring? In other words, bring it to a next level and be the one who is approached up front. Thank you.
A very good final question from Ernst. So there were questions on the financial incentives, also on how you have envisaged the outcomes, the collaboration within the Balkans, and the final question. So please, now you have a very short time to answer those 4 questions there, Igor.
Yes. Zdravo, my Linda. Happy to see participants from this part of our continent into this high-level commission. So thank you for being there. I think that the implementation of this plan is voluntary. The government at this point, we don't have any financial or other things or tools to punish or to even to give incentive to someone to showcase as a positive, which I always cheer for, to show the positive things and not to punish the negative. So I'm afraid that this thing about the not voluntary, so mandatory things. These things, I'm afraid, will come if there is something that can, some big negative impact that might happen in the country, some death. Sorry about talking about this, but this is how things work. Some unfortunate event or some big thing that might happen and might lead to the mandatory actions. From this point, we are voluntary, and I think we are not planning, or the government is not planning, from my assumption, this type of actions. The other thing was about the Balkans.
Tracking the outcomes. How would you track the outcomes of hospitals?
Yes, I answered to one of the commissioners. We have some indicators, and we'll see the outcomes in the next 3 months, I think, and compare it to what was before. I'm not aware that any of our Balkan, of our neighboring countries, have this type of plan, which is with the same name. But I think they're all, as I communicate with them, they're all thinking of making one, or they have some, not at national level, or at some regional activities regarding this. And I think this will follow. This will follow, and we will coordinate regarding this. We can offer some experience. Of course, we can learn from them also.
And the final question from Ernst.
About to the next level, I think we are still not there. I'm afraid to say we're not there, but I have one example of one sector from the social policy sector who approached us and wanted to talk about this action plan and how they can protect their workers and workers from their community regarding the heat. But we have not still reached that level to be, let's say, trusted partner from the economy sector. As I said, we are still at the level of not being enemies, which I think is one level above of the zero position that we started.
Thank you so much, Igor. I actually have some questions from other commissioners, but sadly the time does not allow that right now. But we might ask you to share with us some more information on the very interesting work that you're doing. This has been truly inspirational because, as I said earlier, we are looking at the steps that are being taken around our region and what knowledge there is to be shared and how we can scale them up. And this has been a very important introduction to your work and very inspiring. However, thank you again. Now we plan to have a 5-minute mobility break, but first we will see a very short video from our colleague Rob Butler.
Here are 5 ways that climate change affects your health. Number 1. Heat waves are becoming more intense and more frequent. The European region is the fastest warming region in the world. Heat stroke and dehydration can be life-threatening, especially for older people, the very young, and those with chronic conditions or working outdoors. Number 2. Greenhouse gas emissions are also driving air pollution, further increasing the risk of cardiovascular disease, such as heart disease and stroke, and respiratory problems like asthma. Number 3, a warming planet is changing ecosystems, and the habitats that welcome ticks, mosquitoes, vectors that carry diseases such as Lyme disease, malaria, and dengue. Number 4, climate change affects the quality and availability of fresh water and sanitation systems. Meanwhile, climate-related floods raise the risk of food and waterborne diseases. Finally, climate anxiety is real. It's particularly acute in younger populations. The evidence is clear. Every area of our health is affected. And that's why WHO is stepping up its support to countries to help build climate-resilient, adaptive health systems of the future.
And I now have the pleasure of introducing our speakers on behalf of the Asian Development Bank, a leading multilateral development bank investing in climate change and health in Central Asia. Eduardo Panson is the director of the Health Practice Team, Human and Social Development Sector Office, and Kirti Ramesh is the Senior Social Sector Specialist from the Asian Development Bank. So welcome to Eduardo and Kirti, and please, the floor is yours.
Thank you. And so sorry. Can we have Kirti? Jan has the PowerPoint. So as we talk about, I thought we've been listening to all of the impact of cause of climate change. It's interesting to see our friends from Healthcare Without Harm are here. So as we have started to recognize that, ADB has, in a sense, started to take action, respond to that. And our approach is we need to embed climate and health action within the health systems. Do not see this as something incremental, but rather as we invest, as we support the developing member countries, invest in health systems, in health infrastructure, we really work, can we have the next slide, Adrian, into making sure that the actions, the understanding of climate and health in ministries of health, in the health sector is done, that they have the capacity to do that. So we're doing it basically by first making sure that the message comes out and understood by people in the health sector. You'll be surprised how a lot of people in that sector still do not understand it. We have built up climate and health portal. We have incorporated in health leadership courses, climate and health. We have been conducting capacity building on how to calculate the greenhouse gas emissions of the climate sector, because ministries of health don't like to just hear numbers that comes from global studies. They really want to drill down in their countries and all that. We have also built on something when ADB has been work a lot, which is regional platforms, regional capacity. In particular, in Central Asia, which was part, of course, of WHO Euro, we have CAREC, and Kirti will be discussing that later, because we realize that the more that countries work with each other, they do tend to take action together. And of course, we are a development bank, so when they need to invest in specific interventions, we could help them find the financing, whether it's financing from ADB or from the private sector, or to blend it with some other sources of financing or grants and all that. And of course, we usually provide technical assistance together with the financing. Next slide, please. So in order for us to have some focus, UNADB has launched what we call a climate and health initiative. Of course, unfortunately, right now, a lot of the countries involved in this initiative is not yet in CAREC, but Kirti will discuss more of that. But we're moving to bring in more of our Central Asia countries into this. So what's this initiative? What we're doing is basically trying to provide knowledge and solutions with ministries of health, whether it's disseminating information on climate, we have discussed that, trying to provide financing to incubate innovations, particularly in heat and health. The Asia where we are is among the hottest part of, we have some of the largest cities in the world, and it's quite hot. I'm in Manila right now, it's quite hot to here. With Forge Partnership, of course, we try to minimize overlaps, try to minimize redundancies and so we work closely with our part of WHO, the WIPO and the SHARO. We also, of course, as I've said earlier, build on capacity, because the more that health officials, ministries of health understand what needs to be done, then we see the necessary action. So now, Kirti will now be focused on something that in which we are doing and are working, in a sense, the WHO Euro countries, which is the Central Asia Regional Cooperation, or our current platform. So Kirti will discuss how we're using regional collaboration, regional cooperation to take actions on climate and health. Kirti, you have the floor.
Thank you very much. Good morning, and it's a pleasure to be here. Next slide, please. So with the next slide, we would like to zoom into our work in the region a bit more. And to get an idea of the region that we are discussing, this map shows 8 countries of the WHO European region that ADB works in, which include the 5 Central Asian countries and the 3 South Caucasus countries. This map also shows some other countries that are part of CAREC, the Central Asia Regional Economic Cooperation Platform, that we will be discussing in a bit. We can see on the slide that all countries in the region are and will be impacted by the majority of climate hazards, with differences, of course, between and across countries and varying levels of hazard intensity. Next slide. There's a number of health-related vulnerabilities to climate hazards, and this list is not exhaustive, that Central Asian and Caucasus countries are faced with. And this includes a really high burden of non-communicable diseases, which in actually all Central Asian and Caucasus countries account for the majority of the disease burden. There's also an increasingly aging population in the region, which makes the population even more susceptible to climate change impacts. And importantly, we have varying levels of preparedness of both the health infrastructure as well as health systems that will need investments in the future. On health systems, similar to other health emergency, it's important that we also look at the progress of broader health systems reforms, such as strengthening universal health coverage, access to health services, including primary care, and also having sufficient numbers and distribution of health workers, because all these are protective factors for climate-related health impacts. And they are on the reform agenda of many countries in this region, but will need further support and strengthening. So some of the health impacts in the region, and of course, much more data is needed in the future and much more investment in research. But these include heat stress and heat-related morbidity and mortality, increase in respiratory waterborne diseases, incidence of zoonotic diseases, as well as the encroachment of infectious disease vectors into previously unaffected geographic locations. We see declines in agricultural productivity, which will result in food insecurity as well as malnutrition, and also impact of climate hazards on health infrastructure, which in many parts are quite outdated and not climate resilient, and also health services or roads leading to health facilities, as previous speakers have mentioned. And lastly, it's important to note, and this commission has noted this previously, that health sector also contributes to emissions globally. It's around 5%. We do not have figures for this region itself through, for instance, supply chain and procurement practices, health facility infrastructure, as well as transportation of patients' goods, construction material, amongst others. So all these interrelated challenges require a holistic approach to investments in healthcare systems, infrastructure, but also policy, capacity development, and as previously mentioned, cross-sector responses. Next slide, please. So what does ADB do? We'll start with the regional level and then also speak about some country-based approaches. At the regional level, ADB is engaging through the CARIC platform, which is composed of 11 countries, and was created in 2005 to promote sustainable development through cooperation, including the identification of regional investment needs. And since 2021, this platform is also active in the health sector. Key developments under this platform that relate to climate and health are quite nascent and started more or less last year. So one is the work of the Climate Change Working Group, which are mostly ministries of economy or ecology from the region. And this group has prepared a climate change action plan that was endorsed by the CARIC Ministerial Conference. And this is the highest decision-making body composed of ministries of economy and finance. And this plan has two priority areas in health, which is generally health and climate, but also specifically mentions heat health as a priority, including being part of an early warning system, a potential regional early warning system in the future. At the same time, on the left side, we have a working group on health since 2021 that has increasingly been working on climate and health. There is a regional investment framework for the region that has identified joint actions on climate and health. And given these intersections of these two working groups, they were brought together earlier this year in Bishkek to kick off some joint work. So this is quite recent work, actually. And for 2025, they will table two documents to the CARIC Ministerial Conference in November, which will include a regional decarbonization strategy in the health sector and regionally aligned minimum requirements for climate resilient health facilities. So this is quite an infrastructure-focused document. The first document is essentially a joint approach for assessing emissions baselines in countries, developing country-level strategies, and having a peer-to-peer platform or knowledge exchange in place so countries can support each other in the process of implementation. And as mentioned, the second document focuses on health infrastructure in the region across various asset types and a variety of hazards that can be tailored to each context. And of course, it will need more assessment work in the future before these investments are planned in each context. So some of the benefits, and maybe this could also be a recommendation to the Commission for regional cooperation, and in this case through CAREC, because climate and health and climate change is an inherently transboundary and multi-sectoral topic. So one benefit is drawing in all these different sectors from non-health line ministries and partners, including the ministries of environment, ministries of economy and finance, focused knowledge exchange and peer-to-peer support, supported by having comparable data, standards, and targets, hopefully in the future, to allow also for regional monitoring. Then coordinated approaches. I think this was also mentioned by previous speakers, and regional alignment and standards that can be tailored, and mobilization of financing for implementation, which could include both national level investments, but also regional level investments in regional public goods, such as regional early warning systems. Next slide, please. This is the last slide. And it shows for recent loans in the health sector in the region. Some of them also include technical assistance grants, which feature a range of climate and health actions. Most of them are quite recent projects, so we cannot yet speak about results, but it is important to say that really investing in monitoring is important. And you can see at the bottom for each country respective climate financing that has been calculated for each project. So the actions across the countries, they range from policy work, such as, for instance, the approval of a heat health action plan and a national health adaptation plan under a policy-based loan in Georgia. Investments in infrastructure and equipment for both mitigation and adaptation, such as a new climate resilient nursing school with green building standards that is under a proposed investment in Turkmenistan. And then concrete actions for health systems preparedness, such as the health workforce, early warning systems, monitoring of climate-sensitive diseases, and as the previous speaker mentioned, establishing business continuity plans and protocols in case of climate-related health emergencies and surges of cases. And in the case of Armenia, also strengthening data and monitoring systems. So these actions here are all direct actions on climate and health, but as mentioned earlier, it's also important to consider wider health systems reforms in universal health coverage and primary health care. So for instance, what is not visible in this slide is that in Georgia, most of the policy reforms focus on primary health care, including improvement of screening services, for instance, which can also be regarded and actually leveraged as investments in climate change, because these investments are happening in many countries and these reforms are happening in many countries anyways. And then lastly, I also want to mention that ADB is supporting a range of projects in other sectors with potential co-benefits for health, like transport, urban projects, water and sanitation. But today we're focusing on our interventions in the health sector because this is where Dodo and I are working. And with that, we would actually like to conclude and have some time for discussion and also about potential recommendations to the Commission. So thank you.
Thank you so much, Eduardo and Kirti. Really good to hear about these very practical examples. And just one question from me before I pass the floor to commissioners. But you are mobilizing financing. You are working both with the public sector and the private sector. And I was just wondering whether you are experiencing any obstacles when it comes to mobilizing financing. We talked earlier in this session about the fact that sometimes actors see this as an unnecessary, costly activities that are disturbing their business as usual. So have you encountered any such obstacles?
At the moment, no, we're convincing the case. We usually don't approach this as something that they need to do because it's a requirement. That's the worst thing you do, because our framing is that this is it's embedded in the health system. We've actually been sort of redefining what a health system is, in a sense that being sustainable and resilient should be part and parcel. And in a sense, the ministries of health people are convinced. Okay, now you cannot expect them to look at this as a pure climate projects. That's also not good. because at the end of the day, you're talking with health people. So as long as they're convinced that this actions is part of what it is to be, health system action, that making sure your facility is resilient is essentially part of making sure your hospital works, or putting in renewables is a way to make the hospital sustainable. We have not gotten problems with the most government and private sector providers, healthcare providers are convinced. It is when it's presented in such a, how do we call it? I'm not going to use in a manner where it's like it's too much. It's already something way beyond what the health people are supposed to be doing. That's where we start having questions, and they start asking, why do we need to solve the whole problem for the world, right? But if you frame it as really as part of health work, they're convinced.
Well, good to hear. I have a question now from Sandrine Dixon de Cleve. Sandrine, please, the floor is yours.
Thank you very much to the ADB for this extensive presentation and testimonial. I wanted to come back to both Andy's point before and one of the other testimonials, which is how much we can learn from others, but also come back to the ADB in terms of, and this builds a little bit on your point, Katrin, how can we build the right, then, exchanges, partnerships around health and climate, but taking into consideration also foresight and thinking through new modeling scenarios of what it would cost us if we did not actually enhance our collaboration? I'm seeing the incredible experience that you have, the needs that you have in the region, but many of them are replicated in the needs that we have in Western Europe, Northern Europe, and other parts of Europe. So it's very clear that both the World Health Organization could enable some of this optimization, but how can we collectively, in your eyes, both enable this collaboration and then think through the cost of inaction? Because clearly what we're seeing more and more is that at 1.5 degrees, we actually are going to be upwards of about 3% GDP loss per annum. And at 3 degrees, we potentially could be broader than even 17% GDP loss, in particular in the most vulnerable countries.
Thank you so much, Sandrine. Eduardo and Kirti, please.
Thanks. Okay. So it's a very interesting. One of the things that we've seen that work, right, is first getting health people to understand, right, that they're actually contributing to carbon emission would actually work. And it goes beyond them being told numbers, right? They're used to having global reports, but what actually got traction is a country level work where we could actually tell them, look, this is what you are generating. And so that's a focus of our work right now. We're trying to help countries do this calculation, because the more that it's a country specific, and in our countries that's important for us. The more that, and even more than that, the more it's hospital specific, then the more that they could understand, or industry specific, the more they could take on the necessary actions. So that's that. Now really having a discussion to them that say, look, you need to do this or else. How do you call it? There's so many people that you also have to understand that this is not just this is not the only argument that they're hearing, right? Every disease talks to them like this, right? These are a lot of health ministers have already listened to so many arguments that if we don't do anything on TB, then you have this problem. We don't do anything in NCD. So this is something that's repeatedly being told to them. So one of the things we're trying to do is to frame this discussion so it doesn't come out as if it's just coming from, just a climate story. That we actually try to connect this with NCDs, with communicable disease, and all that. We try to connect this with things that the health people are used to understanding. And so we rather framed it that if we don't do something, the tuberculosis cases will go up. But if we don't do something, you have more dialysis cases. Simply saying you don't do this there'll be more deaths in very gross, in very broad terms, what actually resonates. So we have to be a bit So I keep on saying embedded in the language of the health of the health system.
Great, you're igniting a lot of questions, which is good. And I'm going to pass the floor to the next two commissioners. So I will ask you, Eduardo and Kirti, to note down the questions. And first, we will hear from Omnia El Omrani. Good to see you, Omnia. Please, the floor is yours.
Yes, can you hear me? Yes, amazing. Thank you so much for your presentation. And I wanted to ask, in terms of your work on healthcare system resilience, I was wondering whether there has been more focus across adaptation and mitigation, especially within infrastructure, within energy efficiency. If you can tell us more, and also about what countries that you work with are more focused on.
Okay.
Thank you.
Good question.
Just wait a minute, because I'm going to take another question first.
Okay, sure.
And note this down so you won't forget it. But I also want to pass the floor to Enrico Giovannini, please. Enrico.
Thank you. Just a question related to the previous hearing, and is about the single-use or multiple-use policy, whether this has been part of your projects. And the second one is about the standards for building or designing new infrastructures, climate-proof and climate-resilient, especially as far as hospitals and other medical centers are concerned. Do you have any experience in this field in terms of standards for your projects? Thank you.
Thank you. So Omnia's question first, and then the questions from Enrico. Please, Eduardo and Kirti.
I'm so tempted to answer Enrico first, because we don't really have single, unless a government adopts the single source policy, and it's like, we usually support our governments implement what they want to do. Okay, so is it something that we do advocacy at the moment? No, not that I'm aware of. What's more interesting is the second part of Enrico's question, because part of the work we're doing, not yet in CAREC, is to try to see whether we could convince ministries of health to change their hospital licensing rules. You'll be surprised how a lot of hospital licensing rules in the developing countries are so 1980s or 1990s. So, and we're now trying to look into that, where we have an instrument in the ADB called policy loads, and try to see whether we could include that as among the policy reforms. It's quite hard. It's quite difficult. They're convinced about this, but changing sometimes regulations, licensing rules, a little harder. But I see that as the best way, the best approach. If you could actually convince countries to change their licensing rules, you need that to build anything, then that can make a difference. Now, accreditation, all that, we work on that, but sometimes because it's considered incremental or external beyond licensing, maybe soon we'll do better work there. But the moment for me, it's really the licensing. If we get that to change, and if WHO can come out with new templates on how licensing should be done, where you could actually insist that when you license a hospital, it should be already complying, doing a lot of the climate actions we talked about, that would be great. The first question, this is an interesting question, Omnia, because mitigation easy, because it's all about, we are in infrastructure. We do a lot of infrastructure outside of health, like we do power plants, we do transport and all that. So it's really just making sure that the greenhouse gas emissions are lower. Renewables, so mitigation is an easy discussion. Adaptation, our problem is really, what does it mean? Right? Is it simply making it resilient? We're in Asia. There's a lot of typhoons and earthquakes. So is it simply doing that? Or the argument I always say, strong health system is adaptation by itself. But we get a pushback on that. They say, no, you are greenwashing. You're extending the discussion of what is climate action. But we know now that, it's not just the mosquitoes. That, everybody, there's so much adverse health impact from climate change. So if the argument is, if it's accepted, the strengthening health system by itself is climate change adaptation, that answers your question. Anything we do is adaptation. So, but, I know this is still an ongoing discussion. I don't want to discuss it here, but hopefully with your recommendation would have a much more broader definition of what is climate change adaptation in the health sector. It's not just the mosquito.
You're touching up on a very important subject here, which I think deserves a lot of time, Eduardo. But I have two more commissioners that want to pose questions, and I want to ask all of you to be very short and concise, and we will take them together. First, Hans Brunix, please. The floor is yours.
Yes, thank you for this great presentation. I think it underscores the need to learn from each other and to not reinvent the water when others are already formulating strategies. But here's the question. There is no lack of strategies, not in the region that you are addressing, not in the EU, not in other places. What, in your opinion, when you look at the 2030 strategy, are the critical success factors that will make this different? So in other words, why will it work rather than be a strategy on paper? And the second question is related to your remark that mitigation is easy. Well, the reality is showing that it's not that easy. So in other words, in the region that you are addressing today, what is the connection of an all-of-government approach with mitigation efforts? Because greenhouse gas emissions are not necessarily declining, not in the sector that we're discussing, neither in the energy sector. So while it may sound easy, the practice proves that it's all but easy, or that there is very little political economy willpower behind that. So I was a bit puzzled by your remark there.
Thank you, Hans. And the final question comes from Sir Andrew. Please, Andy.
Yeah, thanks. I mean, fully agree with what Hans has just said. I was going to make the same point, but let me just ask specifically about one of the constraints to the strategy, which is capacity to implement the strategies and also to evaluate them. And we touched on that also in previous rounds of questioning. Do you have a strategy to identify the gaps in capacity, both of the implementation and the evaluation aspects? And do you then have a program or an approach to address capacity deficits at the country level? Because often we find that public health institutions or research institutions, more generally health research, are not well equipped to really evaluate some of these actions. And the ministry, for example, may not be very well equipped to implement or oversee the implementation of some of these actions. So capacity development, it seems to me, is very important. Thank you.
Three questions, and I give you 3 minutes to answer them.
So, George, Hans, just to clarify, when I say mitigation is easy, I'm talking about the health sector. That means the health sector can adopt mitigation measures. And in a sense, you could actually drive the health sector to drive down. We're not talking about mitigation in general. I'm talking health. I'm not trying to solve we're not trying to solve all the problems, right? So just like to clarify when we use that word, that means we could actually imagine that all of the hospitals in Asia can eventually be energy efficient, renewable, and it's a very it's a very reachable goal. And so that's probably clarify the point that I say that is easy. I think what Andy was saying, and it's the question whether there's actually. Sorry, your question is capacity building. So look, the thing we need to understand is at this point we acknowledge that the capacity needs to be built up. So that's why we're going down to countries. We're attacking it. We're not writing a strategy to say how to address it. What we're trying to do now is there are basic skills that we see there are skills we need to be done. So we just go in. So it's a bit ad hoc. You can argue that it's a bit. Whenever a country expressed that they need support, they will provide that. Curtis hands it up, and I apologize. We do a lot of this regional sharing, which we found very effective in other sectors. Countries like to learn from each other. Countries like to compare to each other. Countries love to learn from each other. And so rather than prepare a country-by-country capacity building plan, which is not really our expertise, maybe WHO units can do that. We approach it based on when country needs something, we come in and we provide the support and expertise immediately. Curti, sorry if I allow Curti. And again,
final words from Curti, please.
Yes, just very quickly. I wanted to, I think several times now, the point of implementation capacity development came up. Just to give an example, the regionally aligned minimum requirements for climate resilient health facilities, the reason why we developed this regional document is because we're already investing so much in healthcare infrastructure. So we know we're coming as a bank with financing, with implementation support, technical assistance, capacity development. And we basically use this regional platform to multiply and reinforce actually alignment between the implementation that is happening at the country level already. And as previously mentioned, I think what we do see definitely the need for data. So even if we talk about, so we do assessments before our loans, when our loans are prepared. We look at the country's we look at the climate risk vulnerability assessments, et cetera, before we formulate actions. We do economic analysis as well, because we do need to convince the ministries of finance. But we do this usually for health projects, larger health projects and health sector investments. Where I do think that WHO, for instance, could come in is to further develop some of these tools to support implementation. So, for instance, tools for assessing the cost of investing or not investing actually in climate resilient health infrastructure. I think there's actually more evidence on that. But again, that will also require having more data, investing in data in the countries to be able to do these calculations, because without having that data and having monitoring systems and having the evidence in place, it's very difficult to do these assessments. So I think we do have the infrastructure, but to support implementation. But I think we should leverage these regional platforms as partners to come together more frequently, to listen to countries and really understand what are their challenges to do this implementation, to implement all these strategies. What are the tools that they need? What is it that the ministries of health need to convince other ministries, other sectors to invest? Even the building standards, they're not formulated by the ministries of health, they're formulated by other sectors. So even there, so I think convening as partners through these regional platforms with the countries, listening to them, and developing more implementation guides actually and tools that can really assist them, leveraging the financing that's coming through ADB and other development banks is I think the way to go. We have the instruments. I think we just need to convene better and align our different levels of support that we can provide.
Thank you so much. Thank you, Eduardo and Kirti, for this excellent intervention. Now we have reached our final speaker, Dr. Lorna Benson, a research fellow in planetary health, representing the Pathfinder Initiative. The Pathfinder Initiative is an international partnership led by researchers at the London School of Hygiene and Tropical Medicine. It's guided by the Lancet Pathfinder Commission, an advisory group of experts from diverse sectors and disciplines. And the goal of this initiative is to inform and accelerate climate change mitigation and bring about health co-benefits through evidence synthesis, capacity building, and evidence generation. And Dr. Lorna Benson will highlight evidence-based pathways to net zero that also bring benefits to both climate adaptation and health. So welcome, Dr. Lorna Benson. The floor is yours.
Apologies, my audio there. So thank you so much. It's a real pleasure to be with you and a real honour to speak to the Commission today. So I think we've had the introductions. In the interest of time, I would like to just highlight my three key messages, really. So the first being that climate action delivers fast, measurable health benefits that improves lives within months to years. This is not new information to the Commission, but these benefits arise not just from cuts in carbon dioxide emissions, they come from reductions in methane, in NOx, in ozone precursors, in PM 2.5 and black carbon. And the second point is, despite the scale of opportunity here, we know that about 90% of evidence we rely on is modelled, not observed. And we've heard a lot today about how important implementation can be in determining effectiveness. And models are really important and useful for setting ambition, but they can't tell us what actually happens when policies are implemented in real-world conditions. And so my point really will be that this Commission offers an opportunity to mainstream a culture of evaluation with routine health and equity metrics for every climate action, so we can report on multi-pollutants and multi-benefit outcomes like health and equity, costs and greenhouse gas emissions. So this is particularly important because evidence does show that policy proliferation doesn't always equal policy effectiveness. There was a landmark study recently from researchers at PIC, which analysed about 1,500 climate policies over about 2 decades, and they found only about 10% of those proved effective. And those are the interventions that explain most of the real-world emission cuts. The challenge is that others have been weakly implemented or they've been too symbolic to lead to statistically significant impact. And in addition to that, we still lack that comprehensive evidence about effective implementation for both climate and health outcomes. And so the health case for mitigation and adaptation is immediate, we know that. This slide illustrates evidence from an umbrella review conducted by the Pathfinder initiative in its first phase, and it demonstrates near-term reductions in mortality and morbidity from across 7 sectors and through multi-sectoral actions. And it really emphasises the existing evidence, in short, across 3 key pathways: through reductions in air pollution, through improvements in healthy and sustainable diets, and through increases in physical activity. Yet this is the review that found about 90% of evidence was modelled. And we also lack evidence from other key sectors like waste and sanitation. So studies are still really important. They help demonstrate what can be achieved, but also lessons learned for implementation. And I'd just like to take this opportunity to run through a few case studies. So starting with urban road pricing schemes in Europe, we know between 2003 and 2008, the cities of London and Stockholm and Milan each introduced different road pricing schemes. They were designed to change travel behaviour by increasing the cost of car trips during the daytime. Now, this slide demonstrates numerous quantitative benefits to reductions in PM10, NOx, carbon dioxide, and also traffic injuries, with estimated annual gross revenues in all cities. But it also offers qualitative lessons, like initial public opposition can flip after the benefits are felt, and that the charges, when paired with credible alternatives like reallocated road space, can help to sustain acceptance. It also shows important lessons for policy and evaluation. So each city was able to demonstrate a modal shift from using private transport to public transport, and that's really key when attributing impact to intervention. It collects routine data like counts and emissions, also crashes. They're measured over time, and that allows changes to be confidently assessed. And evaluations took a multi-pollutant lens here, so understanding that monitoring so-called super pollutants can make climate action really politically quite persuasive. So as we scale up the implementation of such initiatives to other settings, local piloting and evaluations remain valuable. They can identify those equity trade-offs, or they can help to mitigate against localised externalities like the potential for spillover pollution or the displacement of road traffic accidents. I'm sorry, I'm struggling to move aside. Okay, and in this next case study, a case study from Victoria, Australia. So this case study studied 1,000 low-income households that received energy retrofits, and that resulted in a reduction of 5,778 tonnes of carbon dioxide equivalent emissions from gas and electricity. They were reduced over the winter period. It also showed further qualitative lessons. It demonstrated the impact of partnering with trusted contractors, and it included tailored education, and it evaluated indoor air as well as comfort. And this has real relevance to Europe. It shows you can link health KPIs to energy efficiency programs like heat pumps or gas removal. It also shows that randomized control trials are feasible for this built environment policy landscape. We know that evaluating food system co-benefits can be quite difficult. Dietary changes can influence... dietary changes can influence health over decades. You don't necessarily see the near-term benefit immediately. It can involve complex behaviours, and it can require linking climate, nutrition and cultural acceptability all into one framework. So in this context, public procurement can be a really powerful lever for climate and health. This case study from Sweden shows how a small scale but high quality trial can really demonstrate those reductions in greenhouse gas emissions. And it can happen at a lower cost and without losing acceptance. And the ingredient here is co-design and careful communication to consider those cultural preferences as the pilot went along. And so shifting landscapes in hospitals, like changing procurement towards sustainable meals, can also cut emissions whilst improving nutrition. So for example, a German hospital intervention cut greenhouse gas emissions by about 27%, whilst increasing staff satisfaction and saving about €4,000 over a 3-month period. And other pilots in Europe and North America can show those greenhouse gas reductions with cost neutrality also. So moving from pilot to scaling up, this routine tracking across hospitals or schools could be achieved by just building in those greenhouse gas estimates, building them into satisfaction surveys or into procurement cycles. And that could happen with minimal additional burden. And as a final case study, I'd just like to turn to Barcelona's superblock model. So this is an approach designed to return public space to green space. And in Barcelona, studies estimate that implementation will reduce rates of premature deaths attributed to reductions in air pollution, to traffic noise and heat, and increased physical activity, also showing potential economic savings. So for any decision maker, this is going to be really important to consider that models do rely on assumptions about how changes in pollution, noise, heat, green space, and physical activity all affect various health outcomes. And these estimates here are based on health impact modelling, but it's also reassuring to see that observed reductions in local superblocks do support these modelled estimates. We also know with nature-based interventions, it can unintentionally drive inequality if not paired with equity safeguards and trade-off monitoring. So further piloting and evaluations can support that equity-sensitive planning or help to avoid or mitigate trade-offs like displacement. So the potential health gains are clear, albeit contextually relevant. So this is a really great example of where we will need more real-world implementation and evaluation to understand how context influences those estimated effects. So in sum, there is now an opportunity to collect systematic health and equity data alongside climate metrics. As an example, health system stakeholders from hospitals to insurers can help to embed routine health indicators, even when the action is in transport or energy or food. Not all evaluation needs to be a complex trial. It's very achievable. What is important is that both co-benefits and trade-offs are monitored for a complete picture of impact. And routine monitoring can include basic indicators like air pollution levels or hospitalization, active travel counts, and including those over time is really critical. So in health systems, patient surveys, energy and procurement data can all be extended or expanding a single school trial to a national school food program could be supported through routine monitoring of things like greenhouse gas emissions, but also costs and dietary health indicators. Meanwhile, more detailed evaluations can link climate actions to multiple outcomes across health, equity, economic savings, social cohesion, where that evidence of feasibility is currently lacking. They could be useful still where actions are more novel or high impact, or they can help to target funding at the most vulnerable populations. And they can also help us to detangle whether actions fail because it was the wrong idea for the setting, or it was the right idea, but implementation was weak. So I think I'll just move on in the interest of time to my final slide. So as a final reminder, we know that well-designed climate mitigation actions across sectors can prevent millions of premature deaths worldwide. That's in the near term, and they can also reduce climate risks from reductions in air pollution through increased physical activity and through more and healthy, sustainable diets. But as the legal landscape evolves, accountability is going to be an increasingly important consideration for evaluation for policymakers and for citizens alike. Symbolic policies lack ambition and monitoring. Credible evaluations help to ensure that we don't lose track of progress and we spend efficiently on effective and proportionate actions. Thank you very much, and I'll stop there.
Thank you so much, Lorna. Now, for the sake of time, I will only allow very few questions, but I would like to say I thought it was very, let's say, heartwarming to hear you say that evaluation does not have to be that complicated, because this is one of the obstacles we see when we are looking at the project ahead of us. However, I would like to ask you, because you gave us some very good and inspiring examples, would you say that the local level might at some point even be more important in implementing positive climate and health action than the national level? Because perhaps it's easier to implement and evaluate because it's kind of closer to home. Could you comment on that? And before you answer, I ask you to take notes. I would like to have some questions from other commissioners. Sandrine Dixon de Cleve, please, the floor is yours.
Katrin, you took the words straight out of my mouth. I want to build on it, though, because I agree with Katrin, Lorna. What is the role at the local level? And clearly, we've seen through C40 and also large-scale local initiatives that this can really enable also an optimized knowledge exchange and working between mayors to learn about experiences. So I'd love to hear your comments about that. But I wanted to bring up another key thought as well, which is already in the 1990s, when I was working on a European auto oil program, we noticed that it was the non-technical measures that actually were the most cost-effective and also had the most positive feedback loops. And I'd love to hear your thinking around that as well, because that obviously is not as costly, and it gets us away from this kind of technocratic technology obsession that the only way we can move forward is to put in place more technological solutions. And then the last question is, what for you are some, however, of the greatest barriers? Because these are very simple experiences, many of which we've heard before, but why are we not scaling them up more rapidly? Thank you.
Thank you, Sandrine. Lorna, if you could give a very concise and short answer to those questions from me and Sandrine, and then we will have final questions after your answer.
Thank you so much. Really poignant questions. So yes, in short, the local level is extraordinarily important, and we do a lot of work with C40, OECD, SDF and various partners to focus on the city level policy setting and working really from the design to the evaluation. I think there's a lot that can be done in cities, and we see that the evidence is mounting, and we're really working to generate more evidence. So I have a yes, but there are only so many actions that can be taken at the city level. I think there's only so much of the kind of systems infrastructure that can also be changed at the city level. A lot depends, of course, on national policies. We also know that really effective policies are supported with enforcement and regulation, and I think that really can come from the national level as well. And cities might have the ambition, but they also require the resources. So I think when a well-supported city might have that decentralized capacity, that is a great option, but not every local area will have that. But the networks and platforms that support that knowledge exchange, I think, are proving themselves to be really critical there. And also sometimes it's not about the size of the action, but it's how widespread the action can be. And we see that also with kind of building interventions. The really effective ones like home retrofits might yield comparably small results, but when implemented across a huge geographical landscape, we can see real changes. On the non-technical, Absolutely. So some of our work with OECD, as an example, is about mindset shifts. Sometimes, and I'll often refer back to Andy's report, which is seminal, but the power of imagination. And I think sometimes the mindset shifts that can happen at the local level or just amongst those with the power to deliver, design and evaluate can be the most critical. So reimagining transport in your city to much broader scopes. Really, I would love to hear your response on that as well, to be honest. And then barriers, I've scribbled the last point. Barriers not scaling is a note I have. Can you remind me of the question?
Yeah, what are the greatest barriers that you still feel are before us that really are not enabling us to go to scale?
Thank you. So I think lack of data has been one, but we actually do understand. We can see, it's clear that there are health benefits. And so I think sometimes it can also be paired with that hesitation to have a high ambition policy. And that's why it's important to see these lessons that citizen acceptability can flip when they start to see and understand the benefits, and pairing interventions with a really appropriate policy mix becomes very important. So education on its own will not change things, but we can shift the needle on cultural acceptability at the same time as systems change. And I think I'll stop there. I can see the time.
Yeah, and we have a question from Ernst Kuipers. Ernst, I would like to pass the floor to you, and again, ask everybody to be short and concise.
Yeah, thank you very much, and I can. Thank you very much, Lorna. First of all, for sharing also these examples and the ambition, and showing also the importance of local measures. Now, on the side, you also mentioned that out of all the measures and interventions that you studied, only about 10% was really effective. So my question is, how do we bring the data and the knowledge and the effect of successful and unsuccessful initiatives together? What would be the level where we would actually both at? Would, for instance, the WHO be such a podium and provide this knowledge and overview?
Very good question, Ernst. I want to, even though the time is short, to say that Andy, Sir Andrew Haynes, that is our Chief Scientific Advisor, of course, you're very familiar with the Pathfinder Initiative, being one of its founders. So I might want to pass the floor to you just very shortly for your thoughts here when we're reaching the end of our discussion today.
Well, thanks, Catherine. Yeah, I mean, these are all great questions, and ones that have preoccupied us as well, very much so. I do think that WHO could be an important source of evidence about effective and ineffective actions, because decision makers need a sort of central source of evidence to come to. They can't do things like systematic reviews, which take us years to do. And although we're trying to shortcut the process using artificial intelligence, machine learning, which I think will be successful in part, we still need to have a sort of central point where decision makers can go and get this evidence and also decide whether the evidence, to what extent the evidence is relevant to their local context. I think that's going to be crucial, because you can't do these studies in every location. So if you're a mayor of a city, you need to know, well, has this city, the city that took this action, in what respects are they like my city? In what respects are they different? How might the policies be impacted on the outcomes in my city, and how would citizen acceptability be reflected in my local context? So you can't do, as I say, studies in every possible city, in every possible location, but with well configured evidence, you can, I think, extrapolate and say, well, this context is a bit like mine, so I think I can implement this with confidence. What we'd like to emphasize, though, is the need for routine monitoring. And as Lorna said, it doesn't need to be elaborate randomized trials, but we do need city-level decision makers and national-level decision makers to monitor routine data. And one example of that is the work we're doing through another initiative with offices of national statistics, because they are crucial in actually registering things like heat deaths, for example, deaths from non-communicable diseases, which can be attributed then to air pollution changes and so on. So building the capacity of offices of national statistics, but also public health authorities that work at the city level are really important. Thank you.
Thank you, Andy. And then I pass the floor finally to Lorna to give her thoughts on the last questions and thoughts.
Thanks so much. I think I would always defer to Andy on this, but how do we bring the successful and unsuccessful together? I think we know what works for net zero, at least, because it's not just about having a policy, it's about the design and the strength and enforcement of that policy. As we go, we need to keep evaluating what works for health at the same time. And then we need to contextualize so we can have an understanding from the evidence synthesis landscape, but we still need to always keep in the back of our mind, I believe that implementation can change things. So understanding the context and keeping it relevant will just be key. It's my brief answer. Thank you.
Well, thank you so much, Lorna. We have reached the end of this second hearing of the Pan-European Commission on Climate and Health. And I want to thank all the speakers who have provided us today with a vast source of information. I think we have assembled a lot of tools in our toolkit today. I also want to thank my fellow commissioners for their excellent questions. And as you can see, we are really into this project, and we aim to deliver very good results in the spring. And I think the speakers have actually given us a lot of food for that today. Now, we have all those tools in the toolkit, but next in our third hearing, we will be talking about governance, which is the key driver of effective and sustained action shaping, because governance creates how priorities, governance shapes how priorities are set, how resources are allocated, and responsibilities coordinated across sectors and across different levels of government. So I think that's going to be a very interesting hearing too, but until then we have a lot of work to do to kind of digest everything that has been said today and continue our work. So thank you for today, and over to you, Sadiqa.
Thank you so much, Prime Minister. And I just want to say thank you all for joining us online today. And we hope that you can join us again on the 2nd of October at the same time for the Commission's third hearing on building political will for a healthy climate future. And until then, take care and goodbye for now. Thank you.